Well, Claire's not here, but she'll be happy that we're starting near the number today. She's on time. But so welcome to Grand Rounds, everyone. Good afternoon. It's my pleasure to introduce Dr. Phatak today. She is a Northwest, considers herself a Northwest native and grew up in Oregon, but was born in India, has lived throughout the world, but she's had most of her early education in the Northwest, including her bachelor's from Oregon State. Then she did an MS in counseling psychology at Lewis and Clark University before moving to the Midwest, the University of Wisconsin in Milwaukee, to get her PhD in clinical psychology. She has developed a research interest and did a postdoctoral fellowship at the Mayo Clinic, where she was an instructor until 2007 when she moved back to the Northwest to join the Department of Neurology here at the University of Washington. She's currently an assistant professor and co-director of the neuropsychology laboratory at Harborview. In addition to some professional society involvements, Dr. Phatak has been involved with many research projects, including on category naming in epilepsy, the use of fMRI and pre-surgical evaluations for refractory epilepsy, and most recently, and what she's going to talk about today, she's the local PI for a study on the effectiveness of behavioral interventions to prevent or delay dementia. And this is a multi-site effort funded by the Alzheimer's Disease Research Council. So we're looking forward to hearing about your work. Thanks for giving us Grand Rounds today.
Thank you. Hello all. So I wanted to talk about the behavioral interventions in mild cognitive impairment. I mentioned earlier there's a push in the community to identify memory loss or potential Alzheimer's disease earlier in stages, differentiate diagnostically from Alzheimer's versus other forms of dementia. And why do we do that? What can we offer them if we can diagnose? We know we can diagnose them earlier. What can we offer them at that stage if we're pushing them to be diagnosed earlier? As Dr. Ransom stated, this funding is a cooperative effort with the Mayo Clinic sites. It was spearheaded by Dr. Glenn Smith, who was formerly at the Mayo Clinic. He has now moved on to University of Florida, and we're collecting data at the 3 Mayo Clinic sites in Minnesota, Scottsdale, and Jacksonville. And then because I did my fellowship here, Dr. Dabrowski launched the Memory and Brain Wellness Center, and so I was involved in some of this work during my fellowship, and I felt we could offer something more for our patients here, and it worked out timing-wise really well. So the Mayo Clinic is funded by PCORI. We're funded locally by our local ADRC philanthropy committee. So dementia is scary, not just for the people suffering, or memory loss is scary for not just the people suffering it, but for the clinicians itself. We've been having more talks with primary care providers who are saying, oh yeah, we know it's dementia, but on the medical records itself, it still says memory loss. Like the patient and family aren't getting a full what the doctor knows because it's overwhelming. This is a scary topic. So this slide is to reassure you that it's scary for everybody. So I know all of you are familiar, and as you'll notice in this slide itself, I'm using both MCI and the new DSM-5, minor neurocognitive disorder and major neurocognitive disorder titles. So transition happens slowly. So this contains both MCI and the minor neurocognitive disorder. So these are the new DSM-5 terminology for MCI, minor neurocognitive disorder, and dementia is major neurocognitive disorder. The distinction is between the ADLs. ADLs remain relatively intact, at this stage, and they are there's a loss of independent ADL functioning in the major neurocognitive. So what is normal aging? It's this is the really bad news slide that I'm afraid I can't get around, but normal aging, signs of aging start in the 30s with processing speed as a cognitive domain. So that's the first affected. Decreased divided and attention multitasking a couple decades later, some word finding difficulty, and forgetfulness. So all of this can be normal, and it's not a cause for alarm. But about 20% of individuals over 65 do fall into the category where it's not just normal aging or normal forgetfulness that can be related to age and qualify for a diagnosis of MCI. You had brought up earlier that dementia shouldn't be interchangeable with Alzheimer's disease, and there are all these other cognitive domains, and it's possible to have a focal MCI or a multi-domain MCI. Often the domains that are impaired can inform about the etiology. So diagnosis of MCI, this is a wonderfully scientific looking graph. But I love explaining it to patients, saying, oh, basically, when you're diagnosed with MCI, it does put you at risk for developing, puts you at a higher risk for developing major neurocognitive disorder. But there are different trajectories. It doesn't doom you to being on the stage. MCI can occur from the, like, a B12 deficiency, the quote, reversible dementias, and you could see improvement when that has been identified. There's MCI that remains stable with a single insult, like a stroke or a head injury. But this is the degenerative trajectory that we worry about. So I promised to talk about more positive things. What kind of behavioral interventions can change this trajectory that someone is on? So in the early 2000s, there was a whole lot of flurry of activity just looking at the concept of cognitive reserve, concepts of physical exercise, living well, whether that has an effect on aging and particularly cognitive functioning. Bronx Aging Study looked at a healthy cohort of older than 75. General headline results was that cognitive activity associated with decreased risk of amnestic MCI over 5.6 years. Another study, religious order study, looked at nuns and priests and come from a secluded, confined geographic location, and so they were able to longitudinally study this group of people, found that higher frequency of cognitively stimulating activities, and this wasn't a prospective group assigned to do any of these activities. These were just individuals who happened to enjoy doing this, and so looked at people who were more likely engaged, so just an observational study, more likely engaged in keeping themselves busy cognitively, delayed the risk by 4.5 years in this group. So habit was constructed by reviewing the literature and looking at the behavioral interventions that have made some kind of an impact, made the needle move somewhat, and what can we do to either delay or change the trajectory that we were talking about in terms of neurodegenerative condition. Habit offers 5 components: physical exercise, computer training, brain fitness, everybody has heard of Lumosity. I think there are many other products. We use BrainHQ by Posit Science. Social support and using calendars. So this comes straight out of the rehab, TBI rehab literature. Calendars work. Using an outside calendar when you're having forgetfulness works. In head injury, can it work for individuals with MCI? And then
using Epic. Using Epic, does that help?
Yeah, I would say that's good brain fitness, learning new activities.
I thought I heard a news report about 10 days ago that luminosity has just gotten into hot water with the feds.
Yes, that's why I was like, I'm not using Lumosity. Well, BrainHQ, the CEO, is a PhD and was interested from the get-go, so they're collaborating. We're not getting paid by them, and was interested in providing information on how much each of the products are helping. So they are not making claims that it's reversible. So the purpose of Habit is to look at how these particular modules affect an individual's self-efficacy, quality of life, and level of independence. So the slip between mild cognitive impairment to dementia was that they're not able to do things independently. If we can delay and allow them to work more independently, then we're delaying that onset of dementia. So Habit's purpose is not to reverse the dementia process, or it's to see how long we can keep them independently functioning, as well as look at their self-efficacy and other things. So Habit is provided in a 2-week program. I mentioned these 5 modules. So during the initial setup, wanted to have a treatment group and a placebo group. The treatment group gets all 5 modules. The placebo group doesn't get anything. People were having none of that. Why would I sign up for your study if there's a chance that I won't get anything? So we had, and because it's funded by PCORI, Patient-Centered Outcome Research Institute, people on our panel include patients and family members. And so we redesigned the study so that we're suppressing one module during delivery of the Habit program. And we'll do the Habit program 5 times over the course of 2 years, suppressing one module each, and looking at if that module was suppressed, how did it change the outcome. So Seattle, we've done 2 sessions. Next week we start our 3rd session. We'll be doing a session in March, or March or April. We'll be doing one in spring, and we'll be doing one in the summer. So if this sounds like something you have patients who would be interested in, feel free to send me an email. We're looking to recruit in spring and summer. I can't promise you though, because so I am involved with the Mayo Clinic infrastructure. The statisticians tell us which module is suppressed, and so they do have to agree to be able to be in, people do get their hearts set on perhaps calendar training or support groups or something like that. And, the catch of the study is that they have to be prepared that one of these might be suppressed. All right, so Habit as a program is delivered over a 10-day period, so Monday through Friday for 2 weeks. We're conducting it in conjunction with Skyline Assisted Living, which is down the couple blocks from Harborview, and they've been a great partner because they provide us lots of rooms, the fitness room, computer rooms. They even provide us lunch for the amount of time it takes us, which is a positive thing. It's a really bonding experience. So that you have this group of people together for 10 days or 2 weeks, you have a captive audience. They participate, the individual with MCI and a partner. Often that's a spouse or a child, but it can also be a friend. And in fact, one of the drawbacks of the people wanting to sign up for the study has been some people haven't been able to identify a partner who can go through the study with them. The study does require that they do it as a dyad. The reason for, so we call them the support partner, the reason for that is we're teaching the support, so we're doing this 2-week intense training and then we're sending them home. We're expecting the support partner to continue prompting and training them over the course of that time. And so they're acting as our proxy, which is helpful. So that's one role a support partner does. Another thing is that caregiver burden is a considerable problem in MCI and dementia, and the Habit program actually has a social support component that's for the caregiver. So obviously this is more useful when it's a family member and there's communication issues that can be talked about. But so social support is support groups that are conducted separately for the patient and for the support partner. So the first module, patient education. I had a patient who gave, when he was 76, he gave me this as his list of medications. I'm having a tough time actually finding medications on this list. They're mostly supplements, and they are familiar from the UCLA paper that has been put out about supplements. So this guy looked up on his own and created this list all on his own, and kind of and was managing. This to me kind of is just exemplifies the level of frustration and desperation that people are just clinging on to anything. What can I do to fix this? So patient education is just looking at providing them the data that we know in terms of, like, CoQ10 doesn't have good supporting data, and yet it's part of the list. It was part of the list, the UCLA list. So wellness education is just providing them kind of didactic information on how sleep, diet, other things affect cognition, and what we already know, as well as being a more sophisticated consumer of the information that's out there. Like Lumosity, if they're saying, because this reverse dementia, reverse cognition, I'm seeing that a lot of claims being made. And I'm seeing a lot of patients come in with Reader's Digest articles saying, no, but you see, this says. So being the wellness education kind of focuses on just being a sophisticated consumer of the information that's outside available. Another component is physical exercise. Most of the data has, in terms of physical exercise, a benefit to cognition or health in general, has been done with aerobic activity. And I don't think anybody here would disagree. Physical exercise is good for the brain. Because we have a large range of subjects, our oldest person enrolled in the Seattle site is 89. So the level of activity that they can do, we couldn't stick everybody on a treadmill, is what I'm saying. So we chose to do yoga. So the people can choose whether to do a chair yoga version or a mat, so people of higher ability don't feel like they're being held back, because we're making sure everybody can participate. And then we've just hired certified yoga instructors who also actually do a small component of meditative or introspective. It's not true meditation, it's just introspective anxiety management is what I know from my therapy or counseling work, which surprisingly does work, because the nice thing about being sequestered to do the Habit program is that we remind them moving from one module to another. When they're doing the brain fitness, logging into the computer, we tell them, use your calendar to write in your password. And so you remind to use the other modules. And when physical exercise was suppressed in the modules that have already occurred, there was just a lot of like anxiety management that that the yoga did that people weren't aware of because it was suppressed for them. So it was just interesting that factor. But we'll see about, because it is a non-aerobic activity, we'll see in terms of how much it's contributing. So I think I'm preaching to the converted here, but exercise decreases risk of dementia. This was 3 times a week and very low level of activity, basically any like walking or any physical activity, so it wasn't significant. It was an observational study, but even that found improvement. This was prospective study where they were assigned for education under usual care group or a 24-week home-based physical activity program, and after on follow-up found a modest improvement on wordless learning recall, which is pretty good. So brain fitness, or EPIC, I guess, how that changes your plasticity. Sherry Willis, along with the group help, has done Seattle longitudinal study, and the active trials have been following people in the Seattle area for a long time. They did this study looking at computer tasks, and the individuals were over 65 from this group. They were assigned to receive training in memory, training in reasoning, or training in processing speed, and a placebo group found a huge improvement in processing speed and reasoning to a lesser extent. So this one is processing speed, huge one for the ones that were trained in processing speed. There was an improvement in processing speed. The ones trained in reasoning improved on the reasoning task, but memory did not improve with these computer tasks. So this isn't surprising findings. Computers are excellent for improving our reaction times, and that's what they're meant for, and that's a good way of improving our Twitter finger or text fingers or other things. But it doesn't generalize to memory because that's a separate process. It might improve your attention and then you're focusing more, but in terms of recall, it's not. The other module is social support and emotional wellness, which are delivered in support groups for habit. There's been some excellent studies showing social engagement and just having social support, having meaning and purpose in life, not only improves quality of life and depression, but indeed improves cognitive functioning as well. This was the best one I could find because it was prospective, it was longitudinal with a good sample size, conducted in Chicago, followed for 7 years, much less likely to develop MCI, go on developing into dementia. How they measured purpose in life was obviously just by asking the individual. So it was just a 10 set of questionnaire on how much meaning do you find in your own life. So it's a qualitative assessment of themselves, but if people felt they were working towards something, it helped with their health, which is pretty remarkable. I was impressed by this study. So sense of meaning and purpose, important reason to get out of bed. This study looked at just social engagement, so not even productive social interactions like the other one was looking at finding meaning or purpose in life, but just social engagement. So they just looked at how many times a week do you get out and do things. And this was 5 practices, primary care practices in England. So a large sample, 13% of the sample had MCI, and mortality risk, and then depending on how much times they got out and did things, how many individuals they interacted with in their lives on a daily basis, the researchers broke them down into low, medium, and high social engagement group, and low, medium social engagement puts you at a higher risk mortality. So systematic reviews, meta-analyses have supported higher risk of Alzheimer's associated with loneliness, decreased social networking, diminished activity level. Now, obviously, this is correlational. It can go the other way too. A diagnosis of MCI or a dementia can sever social ties, and the person can become more socially withdrawn because it can happen at all stages. I've had patients in early MCI where they're recognizing that it's harder to remember names, so they avoid social settings where they have to remember names. So they're seeing less people, and they're decreasing their social networking, which unfortunately then is making them less cognitively active and increasing their risk of worsening. And then calendar training, in terms of just literally we talked to the people in head injury rehab and developed a calendar to be used, pretty much specific small calendar. And the focus is to use this as a compensatory device. So I heard one habit participant called it, "This is my outside brain," of the calendar. In the earlier talk that I did, I showed some data on the Google effects of memory, where younger people are remembering where to look up something rather than what that information is. So we're teaching that, so they're learning that naturally because there's so much information explosion, whereas the older group needs to be taught this concept that it's okay to decide what you want to remember, and the things that are temporary pieces can just be written down and crossed off when they're done. Like the name of the cable guy is not something you need to devote expensive real estate to when you're already having difficulties with remembering people's names. So the overall goal in cognitive rehabilitation in dementia is compensatory rather than retraining function. And the neuropsychological theory behind that is you want to tap into the procedural memory, muscle memory, striatum system, rather than the episodic memory or the medial temporal lobe areas. So shifting so the specific habits that I want them to get into is, oh, I can't remember this, where do I look in terms of a calendar? Just what is your habit that you get into? The reason for this is that procedural memory is preserved in mild cognitive impairment, whereas declarative memory is impaired. So we can take advantage of them being in this stage of MCI. I started this talk by saying, well, we're catching them early. Why are we catching them early? Well, because then we can take advantage of this procedural memory being intact, because in dementia that also gets affected. So this was one of the studies that was conducted early on. So habit grew into a 5-component program over the course of 10 years before 2007, when I was at Mayo Clinic. There was we were just looking at, could we use a calendar the way we teach head injury patients to use a calendar with MCI patients. So the earliest paper of that group from Mayo Clinic, 24 participant and partner pairs got 12 hours of training over 6 weeks. So here, because it's still, we're thinking this outpatient concept, they're still coming in twice a week, 1-hour sessions to learn the calendar. And the efficacy rate was 0.55, so moderate range. And training was done using the Solberg-Mateer model, which breaks down training into incredibly specific directives for learning. Because you habit, according to Solberg and Mateer, takes 21 days to develop, practice every day for 21 days. That's the low estimate I've heard. Other studies have shown as high as 3 months, but it does take daily practice, and if they go a couple weeks, go on vacation or whatever reason, they get out of the habit, you need to restart on an earlier level to regain that habit again. So we actually print these calendars. Occupational therapists were consulted, and they have gone into in a lot of detail. So these are small calendars that can be carried in a man's pocket or a woman's purse. So they have to be usable, functional for anybody. You have to be able to carry it around with you. In fact, one person, like everybody who comes into habit has used some form of a calendar, but no matter how much practice they have at using calendars, I have been able to get them to cohesively develop more efficient strategies. So even people who have already been using it, we've been able to provide some extra efficient use of calendars. But we do actually provide these calendars with the 3 sections. There's appointments, there's to-do lists, notes you have to do, go into extreme detail of how you prioritize, what's the most important to do. When you've completed it, you check it off rather than cross it out. That way you wouldn't be able to read when you go back to know what you were supposed to do. So a lot of specific thoughts with consultation from occupational therapy about what needs to be done in terms of practice. So the patient with their partner come in with a calendar for those 10 hours, 1 hour a day, and we go through putting things in their calendar, teaching the calendar system. We also work, if people feel more comfortable, I have had a couple of subjects who preferred to use the iPhone, and so they're not committed to use this specific one. I create a little folder of the different apps, the reminders app, so they all have the same function, but go through the system with whatever thing that is of their preference. And people have done fine. I'll show you the small data set that I have, but paper or iPhone, people have both. It's their own preference of what they can do. So gory details on calendar training. In that Solberg and Mateer model, learning a new habit is broken down into acquisition of a new habit, application, and adaptation. People move through these 3 stages of learning to use the calendar to form the procedural memory. Hopefully during those 10 days, not everybody has accomplished it during those 10 days. So we meet the people where they're at, try to move them along during the 10 days, but we don't move everybody along. And this is why we have the support partner, because then they're taught to continue practicing this at home. We have them come in again after the 2-week training session, come in again at 6 months and at 12 months to get booster sessions of the training that they had. So our first session we did in June of 2015, which we enrolled 7 subjects or 7 pairs, and they just came back for their 6-month follow-up on in December. So we have a very small case series. Out of the 7 individuals, there was self-efficacy rating data available on 5 of them. Same as meaning and purpose. We know that these are important. How can we measure them? Essentially, we just ask them flat out in terms of how confident do you feel you can tackle everyday life tasks like vacuuming and yard work, like doing errands, shopping. How confident are you that you can do things besides taking medications to improve your memory or cognitive difficulties? So it's a 9-question survey. Subject 1, so the blue line is baseline, and these are the 9 questions. They rated their confidence level on 0 confidence to extremely confident, 10. This is just, so the highest number is 10. Blue is what they started at baseline. The subject was felt pretty confident at baseline. The habit training helped top up his feeling of self-efficacy. After 6 months, it's drifted a little bit, not too much. This subject was more expressive. At baseline, she had varying levels of efficacy. Habit really taught her. These were the household chores, vacuuming, shopping, kind of questions that she felt a lot more confident after the habit session, which is not surprising because we do focus on a lot of practical. We're getting them the calendar, getting them to talk about their daily life. How can we incorporate the calendar in their daily life? So essentially she took those lessons and felt that she was a lot more confident. But in understanding that she was a lot more confident that she would be able to independently do those activities, she felt that her social life would suffer, that she wouldn't be able to independently do the socializing. This is the socializing question on the self-efficacy scale. So that actually fell down after the habit, which is interesting. Then in the intervening 6 months, her husband, who was the support partner, got sick, and they reversed roles, and she was his caregiver because he had surgery, and she was caring for him, and that really wiped her out. And when we saw her at a 6-month, her confidence was at a kind of a low stage. We will see them back again so we did the booster session. We will see them back again at 12 months. This individual as well, same thing. Baseline felt pretty confident. Habit topped up his level of confidence. The other subject, it was her husband who had the health problem in the intervening time. This individual, he had a fall and had health problems in 6 months, and he was kind of getting back on his feet. So this 6-month is him getting back to his level of confidence. This lady, interestingly, she converted. So at baseline, she felt low level of confidence in terms of that she could do any activities related that weren't medication related. She pretty much felt medications would be the standard. Habit helped her realize that there were things that she could do herself. She was able to maintain that level of efficacy. Interestingly, she was the only one of this case series who converted to dementia over the course of the 6 months. So all of this data you're getting fresh off the fresh off the databases here. So we haven't even crunched all the numbers in terms of cognition, but we do know some background information about these people, and she converted over the 6 months into dementia in terms of our level of independence, but her efficacy ratings did not show that change. This individual also, same as the one before, had improved feelings of self-efficacy in terms of medications are the only fix he needs to be looking for. So I tried to highlight the questions that improved here or changed, either improved or declined for him. And so in terms of self-efficacy, those were the cases. There wasn't too much data to do quantitative analysis on. Calendar adherence, a rating scale of 10 points. If they just brought the calendar with them, because we made it specifically so that they can carry it with them, they got a point. They can show me one thing they had put on that day's date, they got a point. To correct entries for the appointment, for things to do, and for notes. So it's out of 10 points. These are the 6 individuals out of the case series, same 6 individuals. Baseline, what they were doing in terms of using calendar really varied. There were some people who were using calendar quite a lot, and there were some people who were not using calendar at all. As I mentioned, I found with Habit that even people who are using calendar quite a lot, that there is something we can teach them. So this is post-Habit. Immediately after the 10-day session, we have them fill out the same questionnaires as they did baseline. So the ones that had no calendar experience were able to improve. The ones who had good calendar experience were still able to improve. In 6 months, there was a drift in terms of how much calendar they continued to improve, to use. So tentative conclusions with this very small data set. Individuals with MCI can learn to independently use a calendar. Behavioral treatment programs improve a sense of self-efficacy, calendar adherence, and self-efficacy following treatment does get affected by declining cognition or other health-related issues. So it's not a one and done. Like they can't participate in a 2-week program and we've fixed them. It's like physical exercise. It's something that they need to keep working at, is what the 6-month sessions are showing, that there is a drift if they don't continue doing that. So booster sessions are useful to accommodate to change health circumstances. And we all want this outcome, but before we get there, we have to slog through what we have now and deal with what I have now. This beautiful lady at the age of 115 was just showing Brock stage level 2, and her cognitive testing was that of 60 to 75-year-old range. So something to aspire to. Okay, I was told to check. That was a French paper.
So particularly at VA, but I'm sure it happens everywhere, but I see a fair number of patients that really know nothing about their medical history and proudly declare they're computer illiterate, and even though they're not demented, they don't have a neurocognitive disorder, they're failing to engage in all the things you say will
Mm-hmm.
help lower their risk for
Yes.
dementia. I mean, is there any approach in individuals like that? I know some of those are durable behaviors, probably related to their
Right.
relationships, et cetera, but I mean, how do you encourage people to read a book or even know what medications they're on and do things like that?
So I try to get in on the motivation they already have. So non-Sudoku players, I don't try to convert to Sudoku playing. If people are watching TV a lot, maybe they can start participating in forums or talks or book clubs or other things. Like get in on what they already enjoy and try to work in your agenda into that. It is absolutely difficult to introduce them to a whole new activity. Although surprisingly, yoga, people came in with leeriness, and I'm talking about, this is also being done in the mood of Westerners, and people came in with leeriness, and I've been surprised at people willing to take to it. So sometimes you can catch them, but mostly not. So I would ride the wave of what they enjoy doing. So if they enjoy doing sports or watching sports, tell them to read up and memorize statistics. That's cognitive activity. Pick something that they have and do more of that is what I've used. By the way, we're Pam Dean, who's a new neuropsychologist at the VA, also trained at Mayo, and so she's participating in this study, and she is expanding the IRB to include VA participants for this town. Yes. Yeah.
I have an off the subject question. I'm part of a study, it's called a precursor study of, I think, 17 medical school classes
Mm-hmm.
that have been followed for many years, since the 40s. And a paper came out of this study suggesting that they were able to distinguish between those physicians who developed Alzheimer's disease from those who didn't, statistically, by looking at their medical school application and coming up with a number for what they call propositional density.
Yeah.
I think is related to the way you write a sentence or something. Now, my mother wrote mine, but but do you believe that?
Well, yes, actually. Well, I don't. I am intrigued by that, certainly. So the concept of cognitive reserve has always worked backwards in terms of, well, the pathology is like this, but functionally they weren't like that. Oh, there must be some black box called cognitive reserve that allowed them to resist the pathology that we see in their brain. But that cognitive reserve genuinely is a black box. Like, there's no operational definition. There's no way to measure cognitive reserve. Our measures of cognitive reserve are reading level, IQ, educational status, general around it. And so I was attempting to define, or I'm interested in defining that forward. And one of the things to look at is propositional density has been measured. I was looking at semantic fluency and network analysis, small graph network analysis to see whether that, because there's these small amounts of paper that are very intriguing, and if there's something to that, could we start teaching people that level of complexity to begin with, rather than looking backwards at them after autopsy, saying, well, these people did have the right stuff. Could we proactively teach groups of people?
So coming to the same of the being bilingual, or
Yes.
So what is your comment on that? What do you think about it? Do you think it matters what language they learn? I mean, what age they learn the language? Can you be recommending to your patients who are in their 60s and 70s speaking of a second language or third language? Do you think, or do you think it's the early
No, so the data is suggestive that people can learn new skills into their 60s and 70s, and that's helpful to them because some of those studies were looking at individuals 65 and older or 75 and older. But again, if somebody is not interested in foreign language, I wouldn't push it on them. But in the way that if they learn anything new, any new skill that keeps them cognitively engaged, that would be great. But the data is suggesting that the bilingual also serves as a cognitive reserve or a resistive is not in older folks who have later learned. All of this cognitive reserve is looking backwards and going like, oh, okay, that should explain that.
I have a question about your trial. Are you also interviewing their care partners about the self-efficacy?
Yeah,
Because
so
lack of insight can create a
yes,
tremendous bias on them.
yes. I just didn't present that, but we are having them fill out, the partner fill out their level of independence, as well as doing memory testing. So I just didn't have that. This is really just fresh off. Other questions? Thank you.
Thank you.